Hello, everyone. Welcome to today's session. Thank you for joining us. My name is Christine. I'm a member of the CASN National Office staff. Before we get started, I'm just going to go over a couple of housekeeping items. Today's session is going to begin with about a 45-minute presentation and will conclude with 10 to 15 minutes of Q&A. Our presentation topic has been proven to be quite popular, and since we are expecting quite a few people, we decided to use the Q&A function in Zoom rather than take questions live. So if you have a question throughout the presentation, press the Q&A button and type in your question. I'm going to be monitoring the questions, putting together a list, and then I will be asking our presenters at the conclusion of their presentation. I'm hoping this is going to allow the presenters to get through more of your questions. Today's session is going to be recorded, so if your colleagues weren't able to make it or you want to review the session later, the recording is going to be available on CASN's website in the near future. This webinar is part of CASN's initiative to support knowledge exchange among nurse educators amid the COVID-19 pandemic. If you have an initiative, research project, or teaching strategy that you think would be of interest to others, please consider presenting your own webinar. Feel free to get in touch with me if you have questions or a presentation idea. You would have my email from receiving the webinar link today. Now I'm going to introduce today's presenters, Andrea Chircop and Ruth Schofield. Dr. Andrea Chircop is an assistant professor at the School of Nursing at Dalhousie University. Her areas of teaching over the past 20 years include community and population health nursing for undergraduate students, supervision of graduate students, and the development of a collaborative certificate in public health nursing for undergraduate students in Nova Scotia. Her scholarship of teaching is focused on the development of entry-level competencies for public health nursing, community health nursing curriculum guidelines, and implementation and evaluation of virtual reality simulation for population health nursing education. Her research is focused on health equity, the social and ecological determinants of health, and healthy public policy. Ruth Schofield is an experienced nursing professor in community health nursing, having taught at McMaster University and Western University. Her research focuses on community health nursing, nursing education, and mental health and housing, with several peer-reviewed publication and textbook chapters. Ruth has more than 23 years of public health nursing practice experience in frontline and management positions in various programs. She has been a chair or general member on several provincial and national boards, and most recently, she became an accreditor for schools of nursing in Canada. She has led several national research projects in the development of CHN standards, competencies, and educational guidelines. And I have to mention that both Andrea and Ruth have contributed significantly to CASN's work in public health and community health nursing on several task forces, advisory committees, and through our community health nursing interest group. For those of you who have just joined us in the last couple minutes, welcome, and I'm now going to turn the session over to Andrea.
Thank you, Christine, and welcome everybody, and thank you for the interest in our presentation today. So I will be talking about the first 20 minutes, and then we'll turn it over to Ruth. We are going to introduce you to Sentinel City 3.0, a virtual reality simulation platform for community clinical. We also want to report briefly on the results of a pilot study that we did on integrating the Sentinel City simulation into a community health nursing clinical course, and then provide you with some examples of how to adapt the Sentinel City to various learning contexts, specifically to our Canadian context. So first of all, for those of you who haven't had a chance to explore what Sentinel City is all about, I'm going to play about a 6-minute clip that gives you a brief overview of what this is all about.
Welcome to Sentinel City 3.0, an interactive and immersive community simulation that lets students earn simulated clinical hours by completing home and family support assessments, clinical care plans, windshield surveys, and other assignments from the safety and comfort of their home any time of day. Sentinel City 3.0 Population Health Simulation comes with 17 complete assignments with AACN Essentials mapping and grading rubrics for easy faculty implementation and customization. Ample faculty resources are included with Sentinel City, such as the assignment catalog and faculty guide, which provides operating instructions and an easy-to-follow map of the individual neighborhoods and their distinct features to help with assignment creation. Sentinel City 3.0 can help train your students in areas such as public health and community health nursing, disaster preparedness, community subsystems, and more. The city is aligned with AACN BSN Essentials. Let's explore how Sentinel City 3.0 works. Get on the bus and select a speed. Want to move faster? Check out the convenient interactive map. Teleport to any location by clicking various icons throughout the city. Each location includes interactive elements that allow the learner to get a snapshot of some of the location's important statistics. Students can take notes and photos of elements they want to record. Demographic panels with key information, such as income level, ethnicity, and age groups, are available. Sentinel City 3.0 includes a family support assessment. The learner is introduced to a family in need of assistance at the Department of Public Health's Family Support Office. The learner will ask the mother a variety of questions while completing a family support assessment.
I have 2 kids, Brayden and Brandy. And sometimes Brandy's dad comes and stays with us for a couple times a week, you know, when he gets around to it.
Next, students will complete a home assessment of the family's apartment to identify environmental, health, and safety hazards, prioritizing them accordingly. The learner will then complete the final care plan, which will incorporate their findings from the family support assessment, as well as the prioritized list of hazards. Lastly, students will develop a nursing diagnosis, including analysis, planning, implementation, and evaluation. Looking for deeper insight? Additional community details can be accessed by clicking the information icon outside of all 15 different city locations. Sentinel City has 4 diverse neighborhoods that represent the vastly different urban communities found across the country. A few key factors influencing the elements of each neighborhood are median income level, population, and average age. This location, ABC Daycare, includes video content that can be used with the complete provided disaster scenario assignment.
We're interrupting this program to bring you this urgent bulletin. WSEN News for You has been informed that there's an emergency situation taking place right now at the ABC Daycare facility located in Southwest Sentinel City.
The interactive Sentinel City 3.0 map allows learners to toggle between locations and citizens. By clicking the Citizens tab, learners can easily find any of the 13 community members. Each citizen provides detailed biographical information, including family and medical history. Students can interact with each citizen through 5 predetermined questions that provide additional details to aid learners in identifying health issues or concerns.
The Public Health Department has information for elder care. They can conduct a variety of assessments to determine what is needed to properly care for elders.
To conveniently interview multiple community members, students can visit the city's community center, which occupies all 13 citizens. A major resource for students in Sentinel City 3.0 is the city's mayor. Learners can interact directly with the mayor to ask him questions around the 8 community health subsystems.
Hello, my name is Franklin Hill, and I am the mayor of Sentinel City. I have information on the following city systems: physical environment, safety and transportation, health and social services, education, recreation, politics, communication, and economics. What system is of interest?
Sentinel City 3.0 provides faculty with a consistent base evaluation while delivering a unique experience for each student. Faculty can easily monitor student participation, hours spent in the city, and progress on specific assignments from the admin dashboard. Here, they can also see the type and location of interactions within the city, and a complete view of the data for the whole class or an individual student. Sentinel City 3.0 simplifies assignment creation and assessment saving time for faculty while providing practice experience and simulated clinical hours for students in an immersive, safe, and fun learning environment. See how you and your curriculum can benefit. Ask for a demo today.
Okay, so that provided you a brief overview. And next, I would like to briefly present the results of a pilot study we did here at Dalhousie with my colleague, Dr. Shelley Cobbett. We basically evaluated the implementation of Sentinel City into a community/population health clinical placement, and it will be published soon. For more detailed information. So I'll give you a little bit of the background and the context within which we did our pilot, talk briefly about the results and the implications. So for us, the driving force was where to find appropriate clinical placements. We did have a curriculum revision that happened about 3 years ago, where we changed the placing of our community clinical and theory course from 4th year down to basically for first year students when they first get introduced to nursing courses. So our placements that we used for 4th year students would no longer be appropriate for beginning students. We also looked at the published evidence around the outcomes of clinical education and found that there was a good support in terms of, in terms of using some simulation. And we then discovered Sentinel City and gave that a try. So basically we sort of looked for opportunities to use some new pedagogical tools. Our research question was whether there's a difference in student perceptions of their learning outcomes between clinical placements with virtual simulation, with a community agency, or with a neighborhood. And those were 2 low-income neighborhoods that we chose for that clinical placement. It was a randomized control trial approach. We had then at the end of the clinical sent surveys to the students with Likert style questions asking about their perceptions of meeting the learning outcomes. We did some statistical analysis with ANOVA, and overall it was informed by a constructivist and experiential learning theory. Placements represented various real life community clinical scenarios as students worked in teams, and they were all at all times supervised by a clinical instructor. The overall outcome for our clinical was for the students to be able to assess a population or neighborhood by gathering and critiquing appropriate evidence, and then to document a population health assessment into a report at the end. And we also want the students to appreciate how the health of populations is determined by society at large. The structure of our clinical was that the students at that time had a 5-hour clinical over an 8-week period. We had 8 clinical groups in our cohorts, 12 students with 1 clinical instructor each. We have 2 intakes. One is direct entry students that begin in May, and advanced standing students begin in September. So we teach every course twice. The nature of the clinical placements for the pilot were that we had 4 clinical groups, and the students were randomly assigned to use Sentinel City. We had 2 clinical groups where students were randomly assigned to an agency that included a student health center, a seniors outreach, residents outreach sort of placement, and an international student center. We also had 2 clinical groups that were assigned to a neighborhood for the clinical. And for the evaluation, we designed an evaluation tool that was based on our clinical evaluation guide that we use for all our clinical. We also looked at the Carson curriculum guidelines for integrating community health in BSCN programs. We basically designed 34 survey questions that were then structured according to knowledge, critical thinking, practice, communication, collaboration, legal, ethical, and professional accountability, and leadership. The results of our study, we had 188 students invited to participate. The response rate was 55%, with 104 students completing the survey, so pretty good. We looked at demographics and virtual simulation background of both cohorts, and so there was no difference in that. In a nutshell, the big outcome was that there were no objectives in which the students in Sentinel City reported percentages lower than students in agencies or geographical neighborhoods. In other words, overall, the Sentinel City group indicated the highest confidence that they were able to meet the course learning objectives. They had a mean of 4.02, and that was followed by students placed with community agencies. And then at the end were students that were placed in the geographical neighborhoods, indicating the sort of less confidence in meeting the course outcomes. So some of the questions here, I'm not going through all 34 questions, but so those are the questions where we found significant difference. For example, question 11, we asked the students, I'm confident in my understanding of a population health assessment. And the students in Sentinel City placement were more confident than the students in neighborhood placements. And this is a busy grid, but it basically tells you that we have outcomes for all students together, and then we sort of separated them into our two intakes, the direct entry, the advanced students, and then we have the students then in the virtual simulation, the agency and neighborhood. So that's how we went through each of the questions. So question 12, for example, I'm confident in my understanding to plan a population health intervention. And with this question, students in the Sentinel City placement were more confident than students in the neighborhood placement. When we asked them about their ability to apply a population health perspective, again, the students in Sentinel City were more confident than students in both the neighborhood and agency placements. When we asked them about their confidence in their ability to collect secondary data, and with that we mean all data that is already existing in terms of literature, in terms of statistics from Stats Canada, from agencies and so on. So students in Sentinel City were more confident than students in the neighborhood placements. And also when we asked them about their confidence in their ability to collect primary data, and that would be data that they would obtain through interviews or focus groups, students in Sentinel City were more confident than students in the neighborhood. When we asked about their ability to analyze data, students in Sentinel City were more confident than students in the neighborhood placements. When we asked about their ability to develop a policy brief, that is one of the assignments that we use to address health equity, students in Sentinel City were more confident than students in the neighborhood placement. And when we asked about their ability to write the population health assessment report, which is the overall big assignment for the clinical placement, students in Sentinel City again were more confident than students in the neighborhood placement. When we asked them whether they would recommend future use of the clinical placements, that's where it's interesting how the results fall. Overall, students, 53% said yes, that they would recommend their clinical. The group in the virtual simulation, there were 40% that say yes, and 59% said no. With the agency, 61% said yes, and 38 said no. And with the neighborhood placement, interesting that 72% of students said yes, that they would recommend it, but they were actually always the lowest in terms of their confidence level to meet the learning outcomes. So that's an interesting finding. A little proviso, the publication, there is an ahead of print publication. There is a typo mistake with this particular question. So if any of you was keen enough to get a hold of that, there will be a correction forthcoming with question 32. We also gave students an opportunity to provide a rationale, so to tell us in their own words why they would recommend or not. So we analyzed that and grouped it into themes. There was the positive experiences included that students found it a very convenient and safe approach to community health nursing. They found it valuable and a good way to ease into the skills of population health assessment before they would actually go out and interact with real people. Then some students who were going into a neighborhood, they found that was an amazing experience and they liked interacting with real people. We had issues of fairness come up, and as you know, students, when they're placed in different clinical groups, they compare with each other. So students in the neighborhood and agency perceived this clinical for them as more time consuming than Sentinel City because they had everything at their fingertips. And students felt that all clinical groups should actually be exposed to Sentinel City to begin with and then try it for real. The support and guidance from clinical instructors is really key, and I can't stress this enough, that the clinical instructors really need to be on board with this and embrace it as an innovative pedagogical tool. It's like you use a new textbook, you need to be on board with it or not, because students really know whether you're doing a good job here or not. So the perceived lack of clinical instructors obviously contributes to student learning outcomes. So that is critical, that the clinical instructors are on board. And of course, the students that had to sit in a room during the summer months instead of going out, they found they weren't impressed with that. Students also picked up that there is no Aboriginal content, because obviously it's US based, but even though they could bring in some of that content. And so students also commented that it is stereotyping at times, which we then try to turn into a learning experience and exploring. So what do we do not to stereotype? So in terms of limitations, of course, this was only a convenient sample from one university, and so the generalizability is limited, but the skills level of clinical instructors is important here again. So basically, our overall recommendation is that the student feedback really indicates a combination of virtual with agency or neighborhood would be ideal. We think it needs to be further explored to look at different multi-contextual pedagogies to teach community and population health. And again, of critical importance is that we need qualified clinical instructors, so they need to also be versed in our theoretical content to give students a good experience. So this was the nutshell, and I'm going to turn it over to Ruth Schofield, and she will present you with examples of application of various Sentinel City assignments. Ruth.
Thanks, Andrea, and welcome everyone. Not unlike many of you, we had at McMaster a need to explore this as an option for a community health nurse. So going through the process, these were some of the thinking and planning and adaptations that I made that I needed to really think about, just overall how, this whole adoption process of a new pedagogy. So I thought, well, it's probably best to start with some guidelines, what's important that's going to inform this decision, identify and address some of the contextual factors. And then obviously I needed to really adapt to this and think of some examples and know that in looking at Sentinel, change needed to happen in the process of adoption, and then obviously looking at an evaluation. Next slide. Andrea, can you give me a next slide?
For some reason, did you turn over the controls to Ruth, Christine?
Nope, I didn't. Oh, there we go.
Okay,
there we
good.
Go. Sorry, there we go. We're back in business.
There you go. Awesome. So obviously the first one of the guidelines that I was looking at was use of best evidence. And what does the evidence say about virtual learning pedagogy? And then how did it align to population-based health promotion and community as partner nursing practice? And that's important because our community health course that we have at McMaster is focused at a population level. So it wasn't focused on community as context. So whatever we were going to use needed to have that perspective. We needed to be able to understand and apply community health concepts and approaches, obviously, that were embedded within our course. So obviously these are some of the concepts that were relevant to our course that needed to be able to be understood and applied through whatever we chose. So primary health care, determinants of health, health equity, Ottawa Charter, and the standards. And a relevance to population health issues in Canada. Alignment with our Canadian public health entry to practice competencies, and was there an opportunity to apply community health nursing process, and also obviously an application of clinical reasoning and judgment skills in the context of community. And how did it align with our design as a program? And similar to Andrea, we had a group learning, team-based learning. We're very strong with self-directed learning, and how did it fit with the clinical sequence that we had for the course. The other guideline is that there were an integration of active learning approaches, and that it could be adapted to Canadian context. So those are just some of the guidelines that I developed as I moved forward. So obviously Sentinel City was one that became knowledgeable to me, and we looked at different ones at MAC, and the pro was that it met most of that criteria, and some of the areas that it was weak in was the area of community as partner, population health, but community as partner wasn't strong. And as you heard in the orientation, it's been adapted to an American context, obviously, with the American Association of College of Nurses Public Health Essentials. And the socio-demographic data was US, and obviously the reading. So to me, those 4 cons were, in looking at Sentinel, were able to be adapted so it could be applied to move forward. So obviously what made it go forward clearly, and I think these are decisions that are critical to moving forward a new pedagogy, aside from our context that was clearly driving it, i.e. COVID, leadership decision was ultimately what led that. In terms of a decision being made within our School of Nursing that we're going to deliver the course and we're going to do it virtually. So there was support there. And it was in that context that I was hired to do. So that was the other part, and using best evidence. And it's clearly a new pedagogy. So that was another contextual factor to think about. This is all new for everyone. We needed to shift the design of the course from a direct clinical placement to an online and virtual learning. And the whole other contextual factor is the faculty and student orientation and support in looking at a new pedagogy. So those are just some contextual factors that needed to be considered. So I was hired and I had 3 weeks. So you can appreciate it. I had to go very quickly because it was decided we're going to do this for the spring term. And so in all fairness, like many of us, having taught and developed the curriculum for the last several years, my head was not in virtual simulation. So I had to quickly rethink my perspective. And frankly, I have to admit, it wasn't a community in direct was my priority, but those views needed to change. And it did. So I went through a learning journey that many of us had to go through. So, and Sentinel City, as I mentioned, was the choice. So I really had to get my head into Sentinel City. So I went through it to help me in the adaptation, for me to really move it towards what we could use at McMaster. I needed to look at all the content. And so that took me some time just to gather all the data that was in there, analyze all the content, the concepts being taught. And then I looked at, as you heard, the assignment catalog, which was a resource to us as faculty to use in the learning experience. And so then I modified those assignments because I wanted to ensure those particular concepts I raised earlier were embedded, and obviously they were more Canadian concepts. and approaches that I wanted to pull in. And then I had to look at how does this align with the course syllabus. So those were the points I needed to look at in terms of the process and the structure related to our course design to adapt it to a virtual simulation pedagogy. Next slide. Whoop, back. So, so not unlike, we wanted to maintain some sense of reality along with Sentinel City, recognizing we could not go to placements because of COVID, but we wanted to have a context of reality. So in Hamilton, what we decided to do was provide options for the faculty in various geographic locations, areas of the city like a neighborhood or a service agency, a school, where faculty and students would have an opportunity to gather some data about that organization, that community. So they had a local picture. So we had both going on. Each student group had opportunities of making a choice in Sentinel City, a choice within the Hamilton City. There's our program for this course, which is in third year, is a 6-hour per week, and we had 12 weeks, so 72 hours. We had small group, as I mentioned. We had 4, but we moved to 6. So that was one change going into this term, which adds to the context, was a new change in the group size. And so we had 2 groups, i.e. 12 students per faculty. The students had, out of the 6 hours, 2.5 were conference time. We increased that because of the importance of support during this new pedagogy and the online context and all that. So the clinical hours was kind of split between the neighborhood and Sentinel City, so the Hamilton City. So it was kind of split half and half. So the remaining 3.5 hours of the day, they split it up between that. And each of the groups with the faculty worked out that balance or that learning time. So there were learning activities already built in the course. Those were maintained, but they needed to be adapted to Sentinel City and the Hamilton City placement. And the students would, because you'll see in the activities, clinical activities they did, i.e. the assignments, we encourage that to be posted so it could be shared with their team members. We continued with midterm and final evaluation. And of course, being a clinical course at Mac, we had pass-fail. So one shift that we did make, as you heard, it was called assignment catalog. To me and to faculty, assignment and students, assignment often means a theory course. So given that we are adapting to a clinical course, we changed the language because we wanted students to really get their head into this being a clinical activity, not a written assignment. So it's just some of that nuances that we wanted. As you'll see in the catalog, they did have a format, and I just tweaked it to modify it to overall what that particular clinical activity was, a description of it, learning objectives, some of the instructions and readings. So I adapted it to readings that were relevant to whatever and Canadian. And then the actual clinical activities that were expected. Now you'll find, sorry, before we go on, and that, you can keep it there, that's okay. As was mentioned in the catalog, assignment catalog, each of the assignments were aligned with the US Public Health Essentials. That was pulled out, but all the, as you'll see, the activities, clinical activities that I developed were aligned with our public health entry to practice competencies. And that mapping has been done, and Andrea had done that as well. So that we haven't included it, but if you move on, we have done that mapping. So this is what I developed. I developed 8. And in fact, and I did A to H. A exactly and B were the community assessment. And that was already similar to what existed. in the, sorry, I've got some noise in the background. Those are my grandkids. So I hope it's not too noisy. So the community assessment already existed in their assignment catalog, but I tweaked it, and I'll show you an example how I tweaked it. So the first one was the windshield survey and a key informant. And the next one, I talked about measuring the determinants of health, because that aligned with our course. Was we looked at community assessment in practice tools, and these were the first one and the second one. So those align very nicely with our course, but I just modified it to the content that was in Sentinel City. Then the remaining C to H were ones that I adapted. And as I mentioned, one of the weaknesses was the idea of community as partner. It did not come out strong in any of the assignments. So for us, we wanted that. I pulled that concept up in many of the activities that, and I'll go into that further. So we had one looking at population health and communication, poverty and health promotion, school health, physical literacy. And I pulled in, which was critical, was the infection prevention and control, given our current scene, and pandemic. So you heard that that was disaster preparedness was mentioned when you heard the orientation earlier, but that was to a different disaster. So I then adapted it to our pandemic. And then the last one, I looked at community development, which really was not embedded at all in Sentinel City, but that was the last activity. So moving on to the next one. So as I mentioned, the community assessment. So basically this is what the instruction or the information that included, as I said, the format of each of the clinical activities all looked like this. It had an overview, a description, objectives, and then what they needed to the instructions, the team that needed to follow. That's including readings as well that you'll see in there. So the next slide then is the activity they as a group needed to do. And if you're able to see it, the indicators are down on I guess your left column. And what you see across the top are the 4 neighborhoods in Sentinel City. So with this particular learning activity for community assessment, it was all about the data that existed in Sentinel City. And so we just went through, similar in the windshield survey that we would normally have done, and they were to look at the data from each of the neighborhoods. And this is where the comparative analysis then came. And we asked at the bottom, which you don't see at the bottom of the assignment, they then needed to analyze, looking at the strengths, looking at the needs of the community based on the windshield survey. They had to include key informant interviews, all those various citizen stories in each of the neighborhoods. So they got a whole picture, and that was intentional, of each of the neighborhoods. So the next slide. This proceeded to go into measuring the health of the community. So that was what we had as a practice tool too. So this is where they get into the demographic data. So this would be the instructions and the readings that went along with it. And then the next slide, actually not unlike what I've talked about, all the indicators. And I should have said that the first one wasn't indicators, is all the various components of a windshield survey. And this are the demographic data. So sorry, I mixed the two learning activities. So not unlike the previous one, the students needed to gather the data, and I pulled out particular sociodemographic data that was common for all neighborhoods. And you can see the 4 neighborhoods. And then the students really needed to really learn that data analysis and identify the trends and think of, and the implications. So what does this mean to the neighborhoods? What's the differences? And they also needed, so you'll see here, they had to do it at the neighborhood level, and then I had them do it at the city level, because some of the data, as you get into it, is at the city level. not at the neighborhood level. So they really got their head into what are some of the population health issues emerging. At the end of this particular assignment, we had an analysis of the first one and the second one, and that's where they needed to pull out overall the strengths and and needs of the community. So moving on to the next slide, I've mapped out here again all this 6 population health intervention activities beyond a community assessment of A and B, and mapped out the various population health issues that were identified in Sentinel City based on the data. So, and then I mapped them through each of the various place assignments so that the students were looking at different population health issues and different health promotion strategies. So for instance, crime rate was identified as an issue. Transportation was an issue. The pharmacy talked about a high opioid use. There was an E. coli outbreak, so they could look at that in one assignment. The issue of poverty, but you can see the dark lettering are the population health issues. So I won't talk about them all, but you can see many of them were woven through the activities that the students could look at. But they could also, when they were looking at the various clinical activities, pull in Canadian data as they move forward in analyzing what they were. Next slide. And this, so in terms of the strengths, and I thought this was important to recognize, though it was not strongly articulated in the assignments, I thought it was really important for me to get my head into it because that would inform how I did the wording in the assignment. So yes, there was some really neat strengths that came out. Citizen engagement, you heard about the mayor. There were other politicians. So there were things like town hall meetings that were talked about, doing needs assessments, invitation to ask questions of their politicians, a coalition building, engagement of faith community, volunteering, the political involvement. So there was a lot of strengths that you could pull out and integrate into the assignments. Next slide. So these are some of the health promotion interventions that were adapted to Canadian. Next slide. And so these were, I just summarized these, but these are the various concepts, as you can see the list on the left side, and then the various health promotion approaches, and they were, as you can see, aligned with the various clinical activities. So they'd have a chance to look at program planning, health education, school-wide health promotion interventions. The outbreak gave them an opportunity to get into surveillance, screening, contact tracing, monitoring. I got them into emergency preparedness, as I mentioned. They could look at community development, policy analysis, media advocacy, campaigns, coalition building, how to influence decision makers, intersectoral. I pulled those in because to me that was an important part of what we generally did in the course, but this is where I think you could adapt. And you could see the concepts that they had to learn about in order to implement approaches. Next slide. And this was just one example of the community development. So as I mentioned earlier, the instructions were on one sheet, and this is where there were key readings that were identified. And then this is what they needed to do. So they needed to identify a population health issue that they heard in Sentinel City. They needed to, well, I can't see everything that's here, but the concept of community governance, concept of community engagement, mobilization. They had to develop an intervention. They had to look at advocacy strategies. And this is where I pulled in the standards, and they needed to look at how that applied to the standards. Next slide. And for us to really map it out over the term, we've used a Gantt chart, which we did with the students anyway, because they developed their capacities. So the first few weeks was all about community assessment and the various stages they needed to go through to gather information. In the last few weeks, which we aligned then with the activities from C to H, were the interventions. So each of those blocks in the bottom of the last 6 weeks or 5 weeks was focused on health promotion interventions. And so they would go from C to H. We've had some feedback. We're still, I mean, this is new. We're just into week 7, I think it is, or 8. So we're still gathering information. We have found, in all fairness, because we are teaching right now in the midst of COVID, students were really anxious in their own context, uncertainty and fear about their future. And they were really needing support. So faculty, in addition to adapting to this new pedagogy, were really finding they needed to do a lot of support of students. There was mixed perspectives, and I think that because of this context, this was new. Did we give enough feedback and support, or not feedback, but supporting students and faculty, because we're in this journey together. Some feedback so far, it's easy to use, it was fun, they liked the clinical activities. Some feedback was it seemed a little static or slow. There some perceptions of it being dated and quite structured, which was different than when they're in the neighborhood, and that's what they're finding. And I think some of the discomfort yet, because it's still so new with the pedagogy. So we're still in our journey of learning, but we're planning on completing an evaluation at the end. So I'm going to stop now. I see we've got lots of Q&As up there. So
yeah, well, thank you, Ruth and Andrea, for that presentation. Learning how to use Sentinel City and mapping it to your curriculum sounded like it was quite an endeavor, a necessary one right now, but kudos to you for that work. So I'm just going to go and start at the top. This question, I think will be for both Ruth and Andrea, but it was posed when Andrea was showing the video of Sentinel City. Is there a strength-based aspect? There's a need to focus, or there is a focus on needs and issues, but are there opportunities to recognize and build on strengths?
Yeah, I think I touched on that, so maybe we could move on, because I did pull out the strengths and we did look at how we could build on that in the adaptation. So I think, though it did not come through in the actual Sentinel City, I think I spoke to that in how I did do it within the curriculum.
Yeah,
Okay.
I think it depends on how you adapt it and how the conversations that you have with your students and the questions that you pose. So I definitely think there is potential for that in there. Yeah.
Okay. And then Andrea, this question's for you. What is the difference between your agency and neighborhood placements?
The neighborhood placements, that was actually quite new. We tried it out. It was basically, we picked 2 neighborhoods in Halifax that are low-income neighborhoods that have a lot of non-governmental organizations that support the community. So, and they are neighborhoods where their citizens really identify with those neighborhoods. And we had the students basically go and explore the whole neighborhood. With one, it was particularly along a particular street where you have a lot of agencies, whatever, community clinics, food banks, needle exchange, organic food markets, all kinds of, things. And so that was like a neighborhood instead of the student being in one particular agency, like a public health unit or something like that.
Thank you, Andrea. This is a question for Ruth. Can you clarify the weekly 2.5-hour conference? Was it a large group, or were those in the small groups of 12 with one instructor?
Good point. I should have clarified that. Of course, it was all online because faculty could not meet with the students. So they met either by WebEx or by Zoom. And so they had the capacity to adapt to meet with either the small group or the large group. So that was really tutor dependent on the need, but there was opportunity for them all to be together. And if they split in, just to give them the support of what they were doing in their particular Hamilton city, or what they were doing within Sentinel City. So yeah, it was dependent on the faculty, but they would meet with the students during that 2.5-hour period.
Okay. I received quite a few questions about sharing some of this work. So are you able to share the adaptations with the Kazan community so each school doesn't have to reinvent the wheel? Or there was a specific question about your first clinical activity.
Sure. It's a good question. I'll probably something in terms of academic freedom or intellectual property, I should say. I'll need to speak to McMaster to really explore that, because it was obviously done in that context. But in that note, it's probably helpful to know that we are hoping to adapt Sentinel City. So Andrea is working with the company that runs Sentinel City. And so we're hoping we can move forward with the adaptation. So some of that could be brought through. Some of the work that I've done and Andrea's done would be a part of it, and potentially others who may have used it. So I think that's yet to come. But in the interim, I recognize that's not going to happen for September. I doubt, right? No. So we'll have to consider what we're going to. So let me get back, and perhaps since I've got emails here, I'm assuming people will have access to our email, then perhaps there can be some follow-up there, and we can somehow get the message out as far as disclosing or sharing some of this information.
Mm-hmm. And I did get a couple questions about the recording. So the presentation itself was recorded, and I will be sharing that with everyone who registered. Another question for you, Ruth. Did you receive feedback from the instructors related to the time required to mark the assignments?
Well, actually, how we did it, given the fact it's clinical, what the students did from how we organized it was the faculty would meet with the students, kind of walk through Sentinel City initially, I believe, so that everybody was familiar with Sentinel City. So that was some of that group conference time, but did not complete the activity. The students would go away and work on the activities, and then the next conference, they talk about it together. So if they needed to create, like one of them, they needed to do a media release. So the students had to develop it. So that was the whole idea. They needed to develop it in their clinical time together as a group. And then they would talk about it in the next conference time together. So there wasn't actual marking, because it's a learning act, because it's a clinical course, but they would receive feedback and some of that critical questions we as faculty will do in talking about what they produced, and building on some of their learning. What was the evidence you used to do this? What any other evidence, this type of thing. They would critically go through that. So there wasn't a grade per se on those clinical activities, because they're meant to be clinical activities. This is that virtual simulation piece. We were helping them learn how to do that, whatever they were doing, whether it was a health promotion intervention related to a media, or they had to develop an intervention in the school health for children related to whatever. One of the population health issues was bullying. So they needed to look at what's a health promotion intervention that we can do addressing the bullying with kids, with parents, and with teachers. They had to develop an intervention using best evidence, whatever. And then they would talk about it.
Okay. And I have a three-part question for both of you. How much does Sentinel City cost? Who is carrying that cost, the student or the university? And do you plan to use it in the upcoming school year?
Well, we will use it again in the fall, because our university will stay online for the fall. Mm-hmm. And there is a range of prices. Obviously, it's US dollars, and unfortunately, our Canadian dollar exchange rate is hurting us right now. But Sentinel City is usually a scale depending on how many licenses you are purchasing. And then the cost goes down. Now, we did initially for the pilot, we had 3 students sharing 1 license. At the moment in our current course, each student gets their own because they can't get together. So each student needs to have their own license from home right now. It's roughly translates into $60 US, that is, though, I think, per student. And the university is carrying this because, you know, we're trying to keep it, to keep the costs low. And if the reason is COVID, then I think we can't push that onto the students. But again, that will be a decision that each university needs to. It's about the same price as a textbook, I would say, roughly. Yeah.
Whereas at McMaster, students did pay that. And so they were looking at a textbook and that. So we did hear about it, but they recognized that unfortunately they needed to have that expense. We did get feedback. Students did express concern about the cost. It hasn't been a big issue, but they did talk about it. And yeah, similar to Dalhousie, McMaster will be online again and doing the virtual simulation in the fall. That's the decision. I don't know about the winter. I haven't heard about the winter, but the fall I have heard.
Just in case anyone in the audience is trying to use it in the fall, perhaps get in touch with us, because we're trying to perhaps do a multi-site evaluation and see how the various contexts, how that plays out, which could give us some good ideas as we hopefully develop maybe a Canadian version. So if you're using it and if you're interested in collaborating on an evaluation, get in touch with us, please.
It's 1 o'clock. I'm just going to ask one final question, I think for Ruth. So was there a synchronous or asynchronous pre-briefing or debriefing done? And if so, did the universities use a particular simulation debriefing model?
Good point. And that's an important piece. We did both. So the asynchronous students, as far as the debriefing, was mostly synchronous. When they met as a group, they were all together at that time. The asynchronous is probably a combination of both, because the students were then expected to do some of their work independent, and I think they had some variation, but they also posted or had some discussion time, because we also had the university online system that we have already existing, A2L or Avenue to Learn. And so there was an opportunity for them to have some discussion in that context, or they could use Zoom or WebEx. There were multiple online platforms they could use. But most of the debriefing was done in synchronous, if I've got it straight, which would have been them being together in conference.
Thank you so much. Thanks to you both. I know there's a lot of people typing in the Q&A box that they're very thankful for this presentation, that it was very informative. So I just want to say thank you very much for your time, for taking the time to put together this presentation. I have taken the rest of the questions that we didn't get to, and maybe there could be some form of response in an email after the fact. But for now, I think we will say goodbye, and thank you again, Ruth and Andrea.
Thank you, and good luck.
Yes.
Yep, good luck and take care, everyone.
Thanks.
Bye now.
Bye.